Bismillahirrahmanirrahim and Assalamu alaikum. Thank you for joining us. This is Tabadlab Policy Roundtable. I believe this is the 10th one that we're doing, but it's numbered 9. And we're lucky today we're collaborating with the Corporate Pakistan Group and with their support, our friend Asfar Ehsan, who would have loved to join us and spoken at this time, but was detained in other sorts of more pressing and urgent issues. Nevertheless, we're grateful to CPG. We're grateful to the whole community of friends and colleagues that have been working with us on assembling this roundtable. We've organized a fantastic group of people. We're very grateful to all of them. I'll just quickly introduce the group. We're joined by Dr. Mishal Khan from the London School of Tropical Medicine and Hygiene. She's been actively involved in the UK response to COVID-19, and we're going to start things off with her today. We're joined by Sayyid Waqarul Islam, who's the CEO of Jaffer Business Systems and has spent the last 35 plus years understanding how data and the public discourse interact with each other, and is a model corporate leader. We've got Naveed Qazi, who's one of the regional heads for Cisco, a very senior executive at Cisco, and has spent a lifetime working with corporations and governments on understanding the use of data in both the public and private sectors. We've got Dr. Samuel Toth, who's a public health specialist herself. She's examined public policy, and particularly either the failure or success, we'll ask her to expand on that herself, but either the failure of the success of development and donor organizations and their interventions, particularly in the health sector. And last but definitely not least, my very dear friend and one of the more exceptional sort of public figures in Pakistan is Senator Dr. Musaddiq Malik. He's not here in his capacity as a political leader, although that is perfectly legitimate for him to speak on politics. But really, he's here today to guide us through and help us understand the public health aspect of all this, both in terms of how we got here, where we are, and where we should move forward. In terms of how we got here, just to kick right off with no further ado, and if I haven't done justice to any of the intros, it's only because my team keeps telling me that I need to zip through the intros and get to the real meat, which is our experts and our panelists and members of the roundtable. So with your permission, all of you, I'd like to maybe hand over to Dr. Mishal Khan. And Dr. Saiba, maybe you could just walk us through, I think, a couple of key things that a lot of us are talking about, but maybe not all of us have the same understanding of. Maybe start with some basic terminology and how the COVID-19 pandemic is being measured. One of the more, especially recently in Pakistan, one of the more discussed data points is something called an R0 or an RO. Maybe start with that, talk a little bit about how the UK's numbers have evolved, how that response has evolved, and then maybe build up to where Pakistan is and where we should be heading. Dr. Mishal.
Sure, yeah, thank you for the introduction. And yeah, I can clarify in terms of so I've been closely observing, critiquing the UK response, as well as sort of the accountability that's gone with it. but my work largely is focused in lower-income countries. So I think in this instance, actually, we can learn quite a lot in terms of how accountability can be generated. So just to answer your questions, first of all, the R naught, it refers to, in very simple terms, on average, how many people are being infected by a single person with, say, coronavirus. So if the R naught is less than 1, it means that slowly, and depending on how much less than 1 it is, the number of cases will decrease. And if it is greater than 1, it means that the number will increase and grow. So essentially, one of the key things we're trying to do is bring R naught below 0. The other terminology that's sort of gone around a lot is, the phrase lockdowns. From a public health perspective, what does a lockdown mean, and how does that relate to R naught? Because lockdown, I think the common terminology, it's referring to people not going out of the houses or reducing sort of mingling of individuals, but it's a very blunt object, and there's many different ways that can be achieved, less mixing of people, so less spread of infection with and without impacting the economy. So these are some of the debates that are happening here in the UK as well. So this discussion about lives versus livelihoods has been very prominent here, and scientists over here have been very, very strongly pointing out that it doesn't need to be that distinction made. And I think that I see that happening in Pakistan as well. But actually, reducing the spread of COVID and saving lives and saving the economy actually happened through the same strategies. So that's something that's happened very much in the UK as well. The other thing that we've seen in the UK is a debate about who's being brought to the table when giving expert advice. So there's a lot of criticism initially of the government that it was not clear who the advisors are, what advice they're giving the government, and how that advice is being used. And to the point where now we've got an independent body that's launched. It's called the Independent SAGE, and that's a group of scientists who are actually helping to hold the government to account by producing their own reports and doing their own YouTube casts. So the lesson I think we can learn from that is that it's really, really important for public confidence and for all of us, people who have businesses in Pakistan, to know actually what decisions are being taken, who those decisions are being taken by, and on what basis those decisions are being made, what evidence, because it can really impact not only how many loved ones we might lose, but also how the economy is going to be impacted.
Thank you, Dr. Saba. I think we have that sort of final sort of set of criterion that you've just articulated in a slide. I wonder if we could have that thrown up on the screen just so that we can reiterate that for those that are watching. I think those probably, could we go to the next one? Those probably right there. So I think these 5 questions, if I've understood you correctly, these 5 questions are vital for the public health response to COVID-19. I think we will come back to this, and maybe I will ask my colleagues to throw this back up on the screen as we move forward. But I thought that maybe we could quickly go to Waqarul Islam, and Waqar Sahab, maybe talk to us a little bit about the sense of panic that certainly seems to have gripped a lot of us, including on the corporate Pakistan group. It's a very palpable sense of real fear right now. Is there any reason for us to be optimistic about how this is playing out right now, or where it could head from here?
So thank you, Musharraf, first of all. So first of all, is there a reason to be incredibly concerned? And I would say yes. Right. And why do I say that? Dr. Mishal spoke about this R factor. Now, we can, as we all know, this is called a novel virus. By definition, that means the playbook for the virus is being written as we are going about it. So there is no set trend, or there is no set formula that how to deal with it. And the formulas as we go along with it are evolving, right? So Dr. Mishal spoke about R factor, which is an important factor, and anything below 0 is considered something to be still concerned about. But now you are within the manageable state. Pakistan R factor as of now, and I'm talking about 3 days ago, was 5.7. So while the world is talking about having an R factor of 1 or less than 1, the lesser the better, we are at 5.7. By definition, that means each person is now infecting 5.7 people. So as an example, if we have close to 70,000 active cases in Pakistan today, that means all of them have possibly infected another 350,000 plus people. And that's why the panic is gripping. What is extremely important is for government to react to the evolving situation and based on data, right? And there are a few myths, and I think it's important that we talk about those myths. And I'm just sharing based on my reading. The first myth that Dr. Mishal also spoke about, and I was listening to New York governor day before yesterday, and I think he had some great points to make. And he said, we more or less have made this debate into a black and white debate, and that's where it's wrong. Lockdown is evil. No lockdown is brilliant. It's health or living. It's not either or, it's both. It's about finding the right strategy to handle the issue. Now, the only possible outcome we want to achieve till the time a cure is available, which from all data that we are getting at an aggressive level, we are talking about possibly December to January timeframe, which means another 7 months to go. And if we are talking about realistic timeframes, that's another 12 months down the road. So what do we do for the window that we have from now and the last 3 to 4 months to another 12 months that are ahead of us? The only thing everyone agrees that where we need to get to is what we call social distancing. And some people do not like to use the word social distancing, though they call it physical distancing. So that's fine. So we want to separate people as much as possible through multiple strategies so that we achieve social distancing, which will help us control the spread, thus delay the spread to the extent that your health system and your economy can be prepared to deal with things in a way that it doesn't go out of hand. And that's why, going back to your question, is there a panic? Possibly not, but is there a cause to be concerned? Absolutely. When each person is infecting close to 6 people, that's a cause of concern. The good news, on the other hand, now everything is relative when you talk about it, and one needs to be extremely careful, in phrasing it in the right way. The good news for Pakistan is that while the world has seen an average death rate of 5.5%, we are seeing an average fatality rate of 2%. So that's a 3.5% delta that we have available, but it doesn't mean that I push my population to even 2%. Why should I? And the way to control it is this R factor, if you like, which is 5.7, and try and bring it down. I wrote a few articles as well, and very quickly to summarize. So what are, in my view, some of the things we should be talking about? I have a problem when people talk about this, the lockdown versus no lockdown. To me, there is no such thing as a lockdown, honestly, because even in the most strictest of lockdown, many things still continue to work, including the entire supply chain. So it's the degree of lockdown that needs to be decided, and how and where you need to do lockdown, and what intensity of lockdown you need to do. It needs to be decided based on our data. I should not be making a decision to lock down a city with 10 cases exactly the same way as a city with 500 cases. They all need to be dealt in a different way. Then the other thing that needs to happen, and that's where I've seen the least amount of discussion in the policy discourse, is we need to move people away as much as possible from the physical world to the digital world. And that needs a policy intervention and a policy discourse. And we need to very deliberately move in that direction so that we create more spaces in the physical world to achieve social distancing.
Waqar Sahab, one of the, I want to move the conversation to Dr. Samuel Toth, and I have a question for her because we were on a few calls together about two and a half months ago, and we were discussing the same topics. So I want to ask Dr. Altaf about that, but I just wanted to, because this question is coming up among some of the viewers as well, and I've gotten other messages as well. I think the R naught that you're referring to might be a different number, because the highest version of that I've seen, 5.7 seems like alarmingly high, ridiculously high. The biggest number I've seen, and the one that really worried me, was the one I saw today. Dr. Adnan Heather, who teaches, I think, at the IBA, his original estimate was 1.16, and he's estimated it now at 2.21. Even at 2.21, it's a massive public health, I would say, emergency. So I wonder if the 5.7 might be referring to something else. It's something we can have checked as well. But
yeah, I think it would be good to get it checked. I agree, because I saw a few graphs and it says 5.7. So it is good to get the validity checked.
Absolutely. And I'll bring that question about data and the right data or the wrong data both to Naveed and to Dr. Musaddiq Malik. But Dr. Samuel Toth, I don't know if you remember, but we were on a few calls at the very start of this crisis with BIDE. These were calls that Dr. Nadeem ul-Haq had organized. And I was listening really intently to Sayyid Waqarul Islam. And I thought, wow, where have I heard this before? And it probably feels to all six of us, and to many that are watching, that this conversation is like Groundhog Day. We've been having this conversation now for at least 2.5, probably closer to 3 months. What does that say about where we are right now, and where's the failure? I would argue that part of the failure is on us. It's easy for us to blame the government and the state for everything, but in what way has the public discourse and the arbiters or gatekeepers of the public discourse, in what way might we have failed to shape the debate in a way that was going to advance the conversation?
Yes, thank you, Musharraf. You're right. This does look like a repeat of the conversation that has been going on for months. I think the reason that we keep going round and round in circles is that there is no central authority or central command or central policy making or central communication which is consistent. So we keep talking about the same things. Let me just step back a little and say that now that the virus has been in play in many countries of the world for almost about, let's say maybe about 12 to 14, 16 weeks, there are certain things we know about the virus now. Although the information is still evolving, there are certain things we know about the virus. One is that countries need to understand that there is not going to be a cure. We have to learn to live with this virus, and like we have learned to live with many other pathogens that are in our environment. And we have to handle this sensibly and intelligently within the constraints and the challenges that exist within our country. There are epidemiologists who are and researchers who have been looking at how the virus behaves, and what they have said is that of course it's a new disease. So like all new diseases, we don't know how it plays out in different populations, but it is very highly infective, yes. And in some populations, it is very lethal. For example, it is now clear that your demographics of the country, for example, older people are much more at risk, and people who have underlying morbidities are much more at risk. So when you are developing a response to a contagion like this, the public health principles are that you do a risk assessment. You see that which part of your populations are at risk. And then you devise your strategy based on that risk. Because if you take a strategy like, let's say, lockdown, you are mitigating the spread of the virus, but at the same time you are putting another set of population and another subset of the population at huge risk. And so the countries need to evaluate that and see if it is worth their while. For example, what India did, now they are researchers who are looking at that strategy are saying that it is not really something that is very useful. Number two, the objective is harm reduction. You want to reduce the harm that causes to your population. So how do you do that? You identify the vulnerable population, you identify how the disease is spreading, you identify where it is spreading, and you look at your own resources. For example, the kind of sort of lockdown that happened in Pakistan, if you look at the data that the Pakistan government itself was giving, you find that during that lockdown, the infections that they were saying, so many found, so many identified, were increasing, as were the mortalities. The deaths were also increasing. So it wasn't a lockdown at all, or it was, a lockdown which was not very effective. If you look at other countries, you find that most of the countries in Europe and in for example, cities like New York, in most of the countries, the number of deaths have not been very excessive. They have been deaths which were kind of would have been natural deaths. Because of the flu season. There wasn't a flu last year, there wasn't a flu before that. So people are now saying, I'm not that researcher, but researchers are now saying that these are those natural deaths. Even in a city like New York, where there has been very quote unquote excessive deaths, there have only been 10 to 15% more than the deaths that happened during a flu season. So what I'm saying is that we need to be cognizant of this fact that we really don't have reliable data from Pakistan, because the data which says that so many people have been found to be positive today and so many people have been found to be positive the day after tomorrow, that is meaningless, because the virus is highly infective. There is a speculation. Some of the researchers are saying that by the time the virus came into the country, a larger proportion of the population was already infected. So I say all of this to say that, going back, Musharraf, to your earlier questions, that, how did we get here and where we are and where do we need to go? So how we got here, this why we got here, where we are now is that we are still in a state of confusion in terms of what the policy should be, who is in charge, who is giving the information, who is pulling all the resources together. There's still confusion about that. The public actually,
Yeah. Dr. Saiba, I want to, because I can tell that you're going to sort of naturally flow into where we should be going, but I wanted to bring Naveed and
sure.
Dr. Malik into the conversation as well.
Sure.
Naveed, it happened a little bit earlier and it happened there again. You might have to unmute yourself before you start speaking, but Naveed, there is clearly a problem. This is the time in human history in which the most data that has ever existed about each one of us and every aspect of us actually exists. And yet, rather than talking about the disease, we have a panel today in which the word data appears, but the word disease does not. How do you make sense of the fact that companies like yours have built, and I'm not blaming your company, but technology, big tech, small tech, has created the opportunity for us to have more data than we've ever had in human history, and yet even on something as simple as a R naught, we don't know. There is no official government R naught published. We know that Dr. Zafar Mirza said it's close to 2. The number that I've just quoted, 2.21, is the most recent estimate. Previous estimates were between 1.1 and 1.4, at which time a lot of us were quite complimentary of the government's efforts, because actually I would argue there was a kind of a lockdown between the 22nd of March and roughly the 9th of April, but it started withering away for many different reasons. The question is, this data issue doesn't seem to get resolved, and this is happening despite all the available instruments that we have. How do you explain this disconnect?
Thank you, Musharraf. I think it's a very interesting scenario, to be honest, obviously very, very challenging. What I'm about to express is my very personal opinion as a citizen of this country, having lived overseas for a while, and having exposure to multiple markets or countries or regions that have reacted to this pandemic. And obviously, I've been a user of Pakistan's healthcare system, so I may have a bias, certain views that I express. So first of all, I think if we look at the response that came from different countries, from China to Iran, to some of the European countries like Italy, that was quite heavily infected in the first place, and now from North America, it's moving all the way to South Asia in terms of growing numbers. Now, first of all, we have to believe in the efficacy of the numbers that are being reported, because we don't really have any alternative mechanism to really do any diligence otherwise. There are theories around that. But for now, I think most of the analysts have to really depend on the data that the governments are actually publishing. So if we really want to analyze what's happening in Pakistan, we have to rely on the data that the National Command Center is publishing. So if you ask me in a nutshell, even though there is this debate about lockdown or whatever you call that, SOPs, forced enforcement, or allowing different sector of economies and citizens to come and open and perform their obligations, probably there has to be a balance. And in most of the countries that have apparently successfully curtailed the first or second wave, they have really opened up their society after they were able to flatten the initial curve, right? And for flattening the initial curve, obviously you need to do testing. You need to extrapolate some of the data. And then, you really need to track and trace some of the infected individuals, and then probably bring about some administrative measures to ensure that you are not really importing more sources of infection. So I'll just give you an example of Singapore. Obviously, probably not the best example to compare with Pakistan, given the size of the country and the very developed healthcare and social support system. But if you look at Singapore, because of the massive amount of international traffic that they receive, they had some of the early indications of the infection. And the government was very brisk to react, because they had some experience from the earlier pandemics like SARS and so on. And for a while, based on the data that was available, and Singapore is a pretty heavily data-driven country, there was a common belief within the government circles and the business community that they have been able to curtail the spread of disease or the spread of infection. But 3 or 4 weeks down the road, we realized that probably the data that was made available was not really looking into two key aspects. One of them was the kind of international traffic that was still coming in, including from places like China. And the second was the workers that were living in dorms that were probably not getting the right kind of testing or visibility that some of the more glittery part of the town or the country were getting, right? And that really generated a second wave, and they had to come down heavily implementing circuit breaker measures. If you compare that with some of the other countries like Taiwan, which has a bigger population mass, or Thailand or Vietnam in the region, somewhat similar demographics, not a very high level of social discipline. And at times, from major cities to towns to hinterlands, the rate of the state also varies quite fundamentally. And in some cases, the healthcare system is not as well developed. But the fundamental thing that I feel different from what we have seen in Pakistan was a clarity of thought in terms of what they want to achieve based on the best possible professional cum administrative advice that they could garner, and then really enforcing that consistently across the country. Probably that's one area where we have lost the ball, right? So the first lesson that we can draw, while we can still debate the efficacy of data, is to ensure that in case of a similar situation in future, we must pay heed to professional advice. And then any decision, honestly, is better than no decision or indecision. And then we should use the administrative machinery of the state to implement that decision, whether that's social or physical distancing, whether that's smart lockdown between major cities and some of the secondary hotspots, or whether it's allowing businesses to continue as usual. I think we need to operate with clarity. In the mid to long term, I think there is going to be a growing emphasis, not just in Pakistan, but also pretty much across the board, on the requirement for having a platform where you have credible data. And that data can be exchanged across public, private sector, and all the other stakeholders if you're talking about healthcare system. And that data has to be federated or confederated. That data has to be virtualized. That data has to be anonymized. And possibly you can commercialize that. So in quite a number of countries, the question would be, where do you get investment for creating a platform like this, right? In quite a number of countries, they have actually gotten private sector on board to garner that investment. Possibly we can do the same so that probably there is less debate about who is providing that number, what's the credibility of that, is it politically motivated or otherwise. So probably these are some of the lessons that we can learn. In the long term, I think the basic lesson is healthcare and some of the other citizen-related services are terribly underinvested. So we really need to bridge the gap between what's a healthy spend on a sector like this and what we are currently doing, and it's a challenge across some of the other South Asian countries as well. So I'll pause here.
Yeah, I want to. There's a couple of things I want to challenge in what you said, and we can come back to these. But I think one, the idea of federating or confederating data, and sharing it across government systems. I always think it's really bad news when Pakistanis live in Singapore because they develop these amazing and unrealistic expectations of what is possible in the public sector. That doesn't mean Pakistanis should settle for anything less. We should always aspire to more. But I just feel like in the current scenario, and this is a question I'll bring to Waqar as well, because I know, Waqar Saab, you've worked on the NADRA board for some time. But before we get deeper into the data question, or rather maybe one way of getting deeper into the data question is for me to pose to Dr. Musaddiq Malik really rather simple question. One of the most impassioned speeches or presentations we've seen in our parliament in this whole period, the COVID-19 period, was early on when you, Dr. Saab, you were quite explicit, you were quite clear, and you were really, there was a lot of compassion in the way in which you put forth your viewpoint. If you were to judge the impact of your words on that day in terms of how much coherence politically, in terms of messaging, in terms of administrative machinery, in terms of data, and in terms of the wider discourse, how have you seen things progress from the point at which you made that case to where we are right now, where we're worried about an R0 of in excess of 2?
So thank you. I personally think that it had zero impact. I think it was good. It was quite passionate. I'd been lobbying for a couple of months across party lines and across even institutions, and I've gone everywhere. Every place. I've not left any stone unturned. And I think that day when I came to the Senate floor, I was just a bit frustrated, and I thought, well, I should give the ideas that I've been lobbying for. I should put them in public domain with a hope that someone is listening out there. And that's probably why it was a little bit more emotional than the usual. But I did not get any response. I think the government has already made up its mind. And I would make a case in this conversation that the fact, we continue to say that it's incoherent, and I say the problem is that it's quite coherent and it's quite clear. And that basically is a problem, because from my perspective, and obviously that's just an opinion, which is partly data-driven, that this coherence is on the wrong side of history. And the decisions and the strategy that we've chosen is probably not a good strategy. So I would just start with, since you began with data, I'll give you some data so that you can understand what is my case for action, and then I will get into the action. So on the 1st of April, we had 2,289 cases. On the 1st of May, we had 18,114 cases, and our government was celebrating. Our government was saying, look, these guys were saying that there are going to be so many more cases, but we only have 18,000 cases, and they were comparing with other countries which had 100,000, 60,000, 70,000. On the 1st of June, we had 76,332 cases. And just remember, 1st of June was 8 days ago, actually 7 days ago. Today is the 8th. And today we had over 103,000 cases. So we moved from 76,000 cases to 103,000 cases in 7 days. And if you just take some kind of epidemiological projection, even if it's a simple-minded projection and not terribly sophisticated, the likelihood is that we're going to have somewhere in the ballpark of about 250,000 cases by the 1st of July or first week of July or middle of July. We can make more sophisticated kind of models. Let's look at another way. Look at the same situation in another way. On the 1st of April, we had 31 deaths. On the 1st of May, we had 417, and the government celebrated that. On the 1st of June, we had 1,621. And today, on the 8th of June, we have 2,100. And if this continues, it's going to be in excess of 5,000 deaths by the time we reach that 200,000 or 250,000 number. That's pretty stark. I mean, 5,000 people dead, and we still may not have peaked. Is that worth our while? Is that a good public health policy? And my contention is, or my viewpoint is, that that is not a very good strategy. And I would come back to this again, but the number of low death in Pakistan was quoted, that Pakistan has an average of 2%, whereas the global numbers are 5%. If you look at the Khyber Pakhtunkhwa numbers, those numbers range from 4% to 6%. They've actually gone over 7% at one point in time and come down a little bit. And the only difference between 5 or 6% in Khyber Pakhtunkhwa and 2% in the rest of the country is that Khyber Pakhtunkhwa is the only province which is reporting deaths or mortality in accordance with WHO. So nowhere in the country, if there is someone dead on arrival, we do the corona test and report him. Or if the person comes from, arrives at the hospital because of a heart attack or a stroke or some other condition which is related to can be related to coronavirus, we don't test them. And that is why KB, where there's a very good minister who was a McKinsey strategist, he refuses. He relentlessly continues to report in accordance with the WHO protocols. He's a PTI guy, but a very good guy. Therefore, their number is 5 to 6%, which is in line with the rest of the world. And the rest of the country, which is not reporting in accordance with WHO, is reporting around 2%. I cannot tell you that this is the reason, but you have to come up with some other reason. That Pathans get affected by it a little bit, they have higher mortality naturally, or because people come from outside, therefore the foreign arrival of infection is at a higher rate in Khyber Pakhtunkhwa. But we're talking about mortality, not the infection rates. Anyway, the question is, what should our strategy be? So far, I've only made a case that it doesn't look very good. So these deaths that I've just shared with you, they may not be these many. They may be 3 times as many because of the way we are reporting them. What should be our strategic intent? You have spoken a little bit about it. And it's not just flattening of the curve, Musharraf. I mean, there is an inflection point, and we have twice over the inflection point. We are almost in the hockey stick stage now, where our growth factor is over 2, which is not good at all. Every country that you've spoken about, other than some countries, Sweden was an anomaly, and you saw their health minister apologize. Their strategy was herd immunity. And about a week ago, he publicly apologized and said, if I'd understood what was going to happen, I would not have gone in that direction. And then people give examples of Brazil and some other countries which I think have crazy policies. But nearly without an exception, every country or most countries of the world have followed a very simple strategy. You basically do a lockdown that breaks the back of the virus, which basically means you bring it down under the inflection point, which means the growth factor or R0 or whatever you want to call it, under 1. And once you've broken the back or the rate of proliferation of the virus, you start to ease out the lockdowns. And everyone knows that there may be, because this is not a cure, therefore we know that there may be another wave. But the waves generally come after 4 weeks, 6 weeks, sometimes 8 weeks or however long. The idea, there's this twin-fold strategic intent. One is to suppress the so to say, the curve. And what does it mean, suppress the curve? Bring the number of infections down to a point where they aren't. The new patients, only consume about 70 to 80% of our critical care capacity. And as soon as countries start to hit between 70% of the critical care capacity or 80% of the critical care capacity, they start to do the lockdowns again, because they know that, there's a gestation period of about 14 days when the patients are asymptomatic. So they know that there's a floodgate coming and their critical care capacity will be compromised. So one objective, strategic objective, is to kind of suppress the curve and make sure that we are not consuming more than 70 to 80% of our critical care capacity. The second, as was being said, is that hopefully within a year, we are going to have some kind of vaccine or some kind of therapeutic which would be reasonably effective. So we need to, rather than taking that loss and having our people killed right now, we want to push out that death as much as possible, suppress it under the critical care, and push it out so that most of the deaths can be averted right now, with the hope that in about 9 months or a year, there's going to be some vaccine, or there's going to be some effective cocktail of therapeutics or some effective therapeutic that would work, and we will be able to save lots of lives. So that is why basically there are two camps. One is saying suppress the curve and push it out. And let's basically make sure in the interim that we do a lot of investments. Countries and many European and the US and many other countries are making lots of investments in these breakthrough innovations, and some innovation would kick in and we'd be able to save a lot of life. And the other is herd immunity. And they're saying, well, people are going to die. Some of these people, let's say 1 million people, have to die of this epidemic. So they die now, they die later on. Who in the hell cares? Let them die now. And rather than taking the economic loss, let's move the economy forward. So these are the two camps. And I clearly am very strongly belong to the camp that believes in suppressing the curve and pushing it out and doing a lockdown to make sure that we buy time. Now, in the Pakistani context, we, for example, how effective have we been? Whether we've done good lockdowns or not so good lockdowns. I tend to agree with one of the participants where they said, we had a lockdown. Yes, we had a lockdown for about 10 days. I've been monitoring it very closely. And for 10 days, there was a reasonably effective lockdown. And that did basically control the proliferation rate of the virus. So after 10 days, our leadership came and we gave all kind of mixed signals that this is nothing but an influenza, and whatever those things were. Let's not get into the political arguments because I don't want to polarize this. But there was mixed signaling. There wasn't actually mixed signaling because the top leadership had, from the word go, decided that they were not going to have the lockdown. Let me give you some examples. So China did a lockdown when they had 830 patients, and they tapered off. They reached the inflection point. Actually, the total number of patients was around 80,000 when they tapered off. The United Kingdom initially went the Swedish way and said we're going to go for herd immunity. And at 3,700 patients, they applied the brakes completely. They realized that they'd screwed up and this was not the right policy. France, Spain, and Italy, they basically applied their brakes, and by brakes I mean lockdown, at about 8,000 to 9,000 patients. And before that, they were going the herd immunity way. And we saw the consequences of that. Even with their infrastructure, we saw what the consequences were. But nearly everyone who then applied the brakes broke the back of this virus, brought it under the inflection point, and then started to ease out the lockdown. Now, this is how biology works, my friend. There was a professor, he was writing, and the chalk fell from his hand. He said, damn gravity. Then he bent down and he picked the chalk up and he looked at the class and he said, but you know what? Gravity doesn't care. So my friend, biology also doesn't care. I mean, we can come up with all kinds of hocus pocus things that it's hot, it's warm, it's this, it's that. This virus is going to behave the way it is going to behave. And we can come up with the BCG hypotheses and a number of other hypotheses, and nothing has panned out so far. I don't know, maybe I've missed something, but I personally believe that our policy was, this entire thinking that there's something special about brown men. If some white man had done this, we would have kind of, I know what we would be saying about this. There's some superiority about us because of which the biology is not going to work. Well, the biology is working exactly in the same way as it's working everywhere else. And I still believe that what we need is an effective lockdown for about 4 to 6 weeks. Why do I say 4 to 6 weeks? Because this virus, one, is infectious for about 14 days. If there's a reasonable lockdown, after 14 days, I wouldn't be able to infect anyone other than the people that I would have affected would be taking care of me, which basically means another 14 days and they'd also be clean. So in 28 days, and you add another cycle, which puts it between 4 to 6 weeks, which has happened everywhere in the world, you would be able to clean up or clear out the rapid proliferation of virus in about 80% of the Union Councils of Pakistan. Then you'd be able to open up 100% of the economic activity in those 80% of the areas. And in 20% of the areas, someplace you'd have soft lockdowns, and maybe in 5-10% of the areas, you would still need to quarantine. And that's how you would manage till some kind of vaccine or therapeutic comes about.
Absolutely. I think that makes a lot of sense. Dr. Malik, as you know, we had a series of proposals about 2 months ago that basically summarized strategies to contain or suppress the rate of infection exactly in the way that you've described. The most, I think, pertinent one for us was the Rashid Langrial piece that essentially defined the terms of a smart lockdown, and it sounded incredibly similar to what you just described. I wanted to pick up a couple of questions that have come in through YouTube. Ahmed Ibrahim, our friend over at Jazz, actually has asked about the BCG, and I bring it up at this stage because Dr. Malik just mentioned the BCG
myth.
Well, great. So let's, maybe Dr. Mishal Khan can address the BCG question, the degree to which it is or isn't a myth, and also not just BCG, but talk a little bit about some of the other things we're hearing out of the UK. I know that there's a big Oxford University push. AstraZeneca, I think, is working on a merger with Gilead. So there's a whole range of things happening. Give us a quick survey of where you think the therapeutic part of this is heading and how quickly, and do mention BCG for the sake of those that are interested.
Yeah, so I can just say, like, BCG, definitely myth. I mean, there's very little evidence of, I think in Pakistan, as was mentioned, we were hoping that somehow we're going to be spared. There's no evidence for this. And so what's really, really critical, and I think just going back to some of the discussion, is this idea that this virus is so new that there's nothing we can do, or we just have to, wait. That's not true. The virus is new, but pandemic preparedness, or preparing for new emerging infections, is a field that people have specialized in. I myself have worked in this for many years, and there's people who worked in it for much longer. There are proven strategies that can be put into place now without a therapeutic, without a vaccine, that can save lives and save the economy. So what is really disturbing to me, and what I believe that the public and businesses should be asking, is why these things are not being done, and who is advising all of whether it's the federal or the provincial governments, on what these strategies are, because waiting for a therapeutic or a vaccine is not the answer. And I would also just bring it back to health systems. For instance, if there's a therapeutic or if there is a vaccine, but in the meantime, we've dismantled our vaccination systems, then what's going to deliver these vaccines? What is it going to come to? And the idea that, Pakistan, I don't want to be a scaremonger, but there is a scenario in which if Pakistan and a handful of countries do not control this well, then there'll be travel and trade restrictions on us, just as was beginning to happen with polio. So we must take this more seriously and engage with, there's examples of countries such as Vietnam, who have managed to control this without a severe lockdown because they've been testing and tracing and isolating cases. And this, I think, is the real critical point. So going back to the UK, even though there was a lockdown, the number of deaths is still now, months after, 2 months after, still at about 300 to 400 deaths are still occurring. And part of the reason for that is despite the lockdown or the physical distancing that was observed, they did not, and they do not yet have a good test, trace, and isolate system. And that is what really brings down the number of people that an individual can infect. So I would not get into debates about whether the R0 is 0.9 or 1.3 or 2. The strategy is going to remain the same, and that is to move R0 down. So let's think about how we can do that.
That's sorry, I thought I lost you there. That's a good sort of way to segue into. I want to take this back to Waqar Sahab. I want to bring this to you. It seems, I mean, one of the maybe most powerful things I've heard anyone say about this is what that last couple of sentences that Dr. Khan just uttered, because essentially she's saying this whole debate around the R0 or the data being too far skewed in one direction or too far skewed in the other, it actually doesn't matter how many deaths, how many tests, none of that matters. What matters is that there's only one way in which this can be contained, and that containment strategy is what essentially we call a lockdown. I think the word lockdown is problematic, especially in Pakistan, but nevertheless, without adopting that strategy, there's no chance of beating this challenge. Do you think it's going to be possible for the government, given the nature of the discourse? And so kind of shifting the discussion as well a little bit, given the nature of the discourse, I mean, I noticed how careful Dr. Malik was there to try and ensure that, the conversation doesn't go in the direction of maybe contamination or toxicity vis-a-vis political preferences or likes or dislikes. But given where we are, do you think that it's likely that we're going to be able to move to a reasonable set of containment measures at this point in time?
So I think, I just want to address a few points, and then I'll come to the question. First is, because it is a pandemic, so looking at one country data without looking at what's happening around the globe, I think is very unfair. So when we look at Pakistan data, we need to compare what's happening around the world, and especially countries like ours with demographics, with our capacity of our institution, with the way people live, with many other factors. Unless we are not willing to do that, any strategy is not going to be meaningful. And no one strategy will fit everyone, right? And there are a few myths. For example, China locked down. China never locked down for a single day. They locked down a city and a province. And that's what we need to understand. Because they wanted to control. So what does lockdown achieve? What it does is delay the spread. Delay the spread to do what? Delay the spread so that you can prepare your health system to take care of the peak, and delay the spread to make sure that your economy is ready to come back, both, not either or. So I'm completely against this thought process that the moment you say no lockdown, you're talking about herd immunity. Nobody does that, except for one or two countries in the world. This term has not been used, right? Now, one more comment. The death rate has varied. It's a fact. I mean, I did some work about 3 weeks ago. I don't have latest data, so whatever I'm stating is about 3 weeks ago. USA had a fatality rate of 4.3%. Spain is 10%. Europe generally has been very high. Italy, 13.9%. UK, 14.6% fatality rate. Now, of course, I don't know the reason, but the fact of the matter is that these are the rates of some of the most developed countries of the world. Now, to say, I would ignore that, I wouldn't. The other thing to be aware is that while there are death rates, absolute numbers in Pakistan are going up, definitely, but the percentage more or less has stayed the same. And, 3 weeks ago, my data says 2.1%. Today, we are more or less at the same rate. Right. So, but in absolute number, the fact that 2,000 people is killed cannot be taken lightly. Right. And you have to have a strategy to make sure that you address it. What needs to change? And do we have a strategy? I think the first, and since it's a data thing, and I'm sharing a personal experience because my family, my two sons went through this COVID experience about 2 weeks or 3 weeks ago. So what's the problem with our data, right? I got calls for the 2 weeks period that these kids were in isolation and going through the recovery process. I must say I must have received good 70 to 80 calls from different people, different agencies. Every single day, 4, 5, 6 calls would come. I must be extremely thankful to them for caring for me and my family. I must also be extremely thankful to them for being incredibly courteous.
Just to clarify, because you didn't mention, just to quickly clarify, these are calls you received from the authorities to ensure and check up vis-a-vis the quarantining and the isolation once your sons were tested positive.
Absolutely. So once it is tested positive, we got it tested from a private lab. As per the SOP, they have to give the data to someone, and then it gets distributed from there. So based on that, I started getting calls. And the good news is I got calls. The good news is they were extremely courteous, very well trained, good to talk to. So that's the good part, right? And since they showed a lot of empathy. So what I'm saying is not as a complaint, but what I'm saying is more what can be done better. Now, the fundamental principle of data is to capture it once and use it many times, right? But here is what happened with almost 70 to 80 calls that I received. Everyone would call me. Everyone would want the same data from me every time they call me, right? And 1 or 2 additions every time. So imagine the quality of data when 10 or 15 or 20 or 30 people, 10 agencies are gathering data, and they would most likely do a data entry of it, try and run some search engine on this kind of data. It won't work. So all they needed to do, to show improvement, while they did a great job in terms of caring for me, all they needed to do is to make sure that they have a strategy for capturing the data well, because that will serve them. And that was not done, or that's not being done. So clearly a huge area of improvement, because the old age, my friend Naveed is sitting here, old age IT or computer industry principle, garbage in, garbage out. So the problem is, if you want to garbage, if you want to control garbage, you need to get the first bit right. And that clearly needs to be done. So what needs?
I think Dr. Mishal wanted to make an intervention.
Please, Doctor, go ahead.
I just wanted to start by clarifying that my initial point, I do not believe actually that a lockdown is the only solution. I was saying test, trace, and isolate. So I just wanted to agree with you that a lockdown, China did not have a lockdown either. And lockdown is a very blunt instrument. And as I said, in public health terms, I don't even know what does that mean. What does a lockdown mean? Because there's different ways in which physical distancing can be achieved. And I just wanted to also completely agree with what you were saying, that if there's 100,000 plus cases diagnosed and this sort of information is being taken from people, well, why don't we have a better picture of, well, what are the hotspots? What are the risk factors?
Exactly.
So, sorry to interrupt, but some of the position on the lockdown.
Absolutely, completely agree, Dr. Mishal. So let me just complete my, what I'm saying. So clearly data capturing strategy is an issue. And by the way, I faced the same issue because when we were in the initial days, me and my family traveled from outside. We did get calls from people, same issue. They were asking multiple data. But here's the problem part from this. Luckily enough, in our case, the symptoms never got serious. Except for the psychological impact of possibly first 24 hours. The rest of it was alhamdulillah quite good, and we remain extremely thankful. So hence, I was not getting irritated with people asking the same question. But think about it: someone having a serious patient at home, and he's getting these calls every time, and they're asking for the same data time and time again. That is not empathy, even though they are extremely courteous. You are being extremely discourteous with the same information that you are collecting. So they need to fix their data collection strategy clearly to make sure that and since we have two experiences, one with travel and one with actual COVID experience, in both cases, consistent mistake. Nobody has looked at the fact that you need to capture data once correctly and use it multiple times. The second piece is to have a mixed strategy, right? And the strategy has to be what nobody should disagree, and if the communication and the agreement needs to come out very strongly that till the time a cure is there, which is 12 months, and you need to plan for 12 months. So this myth again that 2 weeks lockdown will solve anything. Lockdown is not a solution. It's a strategy to achieving physical or social distancing. And that's one of the strategy should be used, but it should be used in a very selective way, in a very data-centric way, and whatever you define the lockdown. Second is move towards digital. And I must confess, I have not seen any policy work beyond development few apps on this. How do you achieve social distancing when you continue to focus on a physical world model in a physical world decision-making process? We, our decision maker and lawmakers, need to think that there is a physical world. Because of COVID, through policy discourse, you need to construct and fast a digital world. And both needs to be blended in a strong way. And this work from home or remote working is a classic example where possibly 4 months ago, we would have never thought about doing this kind of discourse in a virtual environment. Today we are here. So it has happened in this country. I've seen senior level meetings happening in remote, but why can't we make it a lifestyle for at least the next 12 months? So we need to move away from this entrenched physical world mindset to realizing that there are two worlds that exist, and now they need to exist at an accelerated pace where you need to reduce the physical world as much as you can. It needs to still exist, can't go away, but you need to construct very fast, very aggressively a digital world so that you can move people away from the physical world into the digital world. If they don't do it, then either way, whatever you do lockdown, you don't do lockdown, you do complete lockdown, you kill people. One way or the other. You do mild lockdown, you kill people through other means. So you need to have a multiple pronged strategy and not an either or strategy, both health and living.
I couldn't agree more, Vakar Saab. At the end of that, essentially what you're saying is kind of exactly what, and we alluded to this before, this is exactly, again, I would say broadly the Rashid Langreal sort of, and I keep using his name because, he's written the most detailed treatment of this. It's the argument that Musaddiq was making. It's the one that Dr. Malik and Dr. Khan have confirmed. Dr. Samuel Toth, I wanted to bring this to you, and I have a darker place that this conversation unfortunately has to go. And that is that what we're talking about seems to be not just a will issue, but also a capacity issue. And what I mean by that is you do not have a public sector pipeline that can process data clearly from the example that Vakar just gave of the number of calls he was receiving. So for us to then expect that the government would have a multi-layered digitalization strategy in which BISP and SAS would get digitalized, where smart lockdowns in UC1 and no lockdown in UC7 would be possible, all of those things almost seem like a pipe dream. But the most prominent or most profound way in which this lack of pipeline or lack of capacity exists is actually in an area we haven't touched upon at all today, which is Dr. Toth, the state of healthcare workers, the state of doctors, the state of nurses, the state of our hospitals. So again, going back to the data, we have all this data on how many PPEs we have, how many vents we have, how many events we don't have. All of those numbers exist. But at the end of the day, the numbers don't really mean much because, at least in some cities now, we're beginning to see a pileup. What are you hearing from the medical community, which you yourself are a part of? And what is your prognosis? How bad is it right now? And how bad do you suspect it might get in terms of the state of hospitals, emergency wards, COVID-19 units? Dr. Altaf, we can't hear you. You're on mute, so you'll have to unmute yourself.
Okay.
Start again now.
Okay,
Thank
as happens in Pakistan, yes, as happens in Pakistan, there is huge amount of confusion in terms of what is reality and what is just, something that's talked about. If you look at what the policymakers are saying, the special assistant to the prime minister is on record saying that the hospitals have tremendous capacity. They are only occupied 30%, and we have, beds and ventilators available for coronavirus patients. If you call the hospitals are overcrowded, and the frontline workers and doctors are falling sick, and they are leaving their posts, and they are complaining of being overworked and carrying too many shifts. So what does that tell you? What is the reality? That tells you that there is no plan. There is no consistent, kind of strategy in terms of how to use the very scarce resources that you have. And one of those resources is the doctors and the nurses and the frontline workers. And that information is not shared anywhere. One can only get that information from the pronouncements and the news items in the newspapers. So yes, that goes back to what Dr. Khan was saying, that who is in charge and who's advising the government and who's looking at, even however flawed and however sporadic and however scattered and however fragmented the data is, who is looking at all of that and bringing it together to form a coherent picture so that the government can take a consistent stand in terms of what needs to be done. So the capacity issue, and the capacity issue is an enormous issue. The thing that baffles me very much is that, the government has a huge infrastructure spread out into the districts, which it refuses to utilize. Everything is brought into the cities, into the large city hospitals. All the testing is being done over here. All the isolation is being done over here. All the quarantine is being done in the cities. And all the district hospitals and the tehsil hospitals and the district level staff are just waiting, idle and twiddling their thumbs. I want to alert ourselves to one of the things that we've talked about, looking at these deaths that are happening. And Malik Saab also talked about it. I think we need to keep in mind, horrible enough as every death is, and the human life is very precious and has a dignity attached to every life. But the fact remains that we do not have information whether these deaths have happened because of COVID or in relation to COVID. Because what has been happening is that because of these lockdowns and these hospitals being closed and their outpatient departments being closed, doctors' offices being closed, people have not been getting the routine health care that they required. So people are dying of heart attacks. People are dying of lack of medicine. I know a lot of people who have not gotten their chemotherapy on time, who have not gotten their dialysis on time. So these, we need to take these number of deaths that are happening in hospitals with a little bit of a pinch of salt and have a little bit of a wider perspective in terms of reducing the harm to people, and when we talk of reducing mortality levels. And I quite agree with the panelists who have said that there needs to be a multi-pronged strategy. Lockdowns are good. Lockdowns are useful when they come at a certain point in the life of an epidemic. And if we are talking about a lockdown, that only happens if either your population is so scared of you that you lock them in and they stay in, or they are convinced that this is in their best interest and they cooperate with you. With the lockdown in Hubei, the Chinese government had 3 teams, different teams, who went into each house every day, and they evaluated people for new infection, and they removed people who were sick for something else. They took them to the hospitals. So if you want to do a lockdown, then you really have to be serious about providing people food, providing them, funding, putting money in their bags, and also helping them with the kind of help and support that they need. So if it's something that you can't do, just saying that it should be done, we need to keep our constraints in mind. So I'll stop here.
Keeping our constraints in mind, Naveed, I want to come back to this. I mean, in a sense, and forgive me, I just take liberties with everyone, but especially with you. I have a long record of doing so. You say, I'm going back to what you said earlier, and I'm going to pick on it a little bit. You said about confederating the data. That's the right solution, clearly, because Vakarul Islam has just given you a real life example of the fact that across the same individuals and this wasn't the national level. I'm guessing most of this was provincial or Karachi-based authorities, given that I know that Vakar Saab is based there. When we can't get right, and at that time, by the way, when he had this COVID-19 issue within his family, that was probably a good month ago. So in terms of the total burden on the system, 3 to 4 weeks ago, in terms of the total burden on the system was not overflowing. My real question, and that's kind of the question I asked Dr. Altaf as well, Naveed, is that when the caseload expands or explodes beyond what our big city hospitals are capable of catering to, at that point, this debate about the data will seem quite useless, because at that point, it won't be the data that's the problem. It will be the human beings involved in the data. At the extreme end, the number of fatalities will exceed the capacity of potentially hospitals to process, hospitals to store, and graveyards to bury. Are you worried about, in the short run, what that scenario might look like? And in the longer run, what are some more practical things beyond confederating the data that can actually fix this? You know how government works. You know what the procurement challenges are. You know what the limits of capacity in our system are. We can't keep proposing. I don't suspect. I mean, I of course will. I'm a development consultant, as you know. So we'll keep proposing the same old solutions till the cows come home. But for the sake of Pakistan, some of our solutions have to be actually implementable and usable. Would you not agree?
So, honestly speaking, if we take the data thing aside, right, I personally believe that in a country like Pakistan, with a fair bit of talented people, you can actually create a data repository and come up with a certain quality benchmarks to configure that there. But that's a mid to long term thing. That is not going to happen on 2, 3, 5, 6, even 12 months, to be honest. If we refer back to the debate that we started with, right? So there is a lockdown lobby, and then there is a lobby that wants to open up pretty much all social strata and business and so on. I personally think in a country like Pakistan, and you compare that with similar demographics, you would need to go back to somewhat more stringent containment. I don't think there's any other solution. Especially, and I'm by no means an expert on that. I'm purely talking about my views as a Pakistani who is quite well connected with the reality in our urban centers and also in the rural areas. So we'll probably need to go back to more stringent form of containment. Probably it's a bigger challenge in the bigger urban centers, which is roughly 25% of the populations, coming down 40% of the overall urban population base. And then, as we have seen in the smaller towns and villages and so on, as long as you can curtail or control intercity movement in the period where you are trying to confine or curtail, whether it's inter-district or intercity movement, if you can curtail that, then probably you can fix the problem of flattening the curve. That's my very honest opinion. And it will honestly come to administrative will of the state and the governance structure. Now, beyond that, in the very near future, I'm talking about next 3, 4, 5 weeks, the best we can do is bump up as much capacity as we can, right? Which is arranging probably more high dependency unit beds, bumping up the ICU capacity, coming up with more oxygen feeding it. arrangements, and possibly sending some of the patients from tier 1 cities to adjoining district headquarter hospitals or so on. So that, in my view,
Naveed, that would be, sorry, that's a really interesting proposition, because that would be literally the first time, I think, at least in my lifetime, that we would see urban to peri-urban or large urban to smaller urban traffic for service delivery. This has been one of the great, preoccupations of those that focus on public policy, like so many of us, that so much of the burden on our cities' services is actually the burden of peri-urban and surrounding rural areas. And what you've said is incredibly powerful, because what you're saying is we're going to see our cities max out their capacity to deal with this challenge, and you're going to see overflow capacity being dealt with in the secondary or second tier cities. Is that, am I hearing you right?
And in all honesty, and we can look at the data for that, there is very little incremental capacity available, and we have quality challenges. Psychologically, some of the people would not want to go there. But I'm saying, we have seen frantic calls from friends on WhatsApp groups and our social network where people are literally not able to find beds, right? In reasonably acceptable quality standards following hospitals. And some of them obviously have gone to the next level. So probably if you can find a bed with reasonable level of healthcare an hour away from where you live, or 2 hours away, probably that's not too bad an idea. But there are quality challenges. If you go to an average district headquarter hospital, it's not really a very pretty sight. But to me, realistically, looking at where we are, we probably had a 6 to 8 weeks advantage or a lead time, right, to really articulate our response. And probably everyone did their best. But I think it was a little bit of a lacking story at the end of the day. So where we are right now with 100,000 reported cases, probably adding 5,000 every day. And again, some people think the actual number of cases are higher than that. I think in the next couple of weeks, we'll have a fair bit of challenging situation dealing with that. So that will require, in my view, administrative will. Honestly speaking, if you also look at certain districts that have gotten less number of cases or less proliferation of this infection than others, if you study that in a bit of deeper detail, the district administration there took the free hand. And for a good 2 weeks before it was really diluted, they really implemented the stringent confinement measures, and it worked a bit better than other places. So probably we'll need to use the administrative machinery, I hate to say that, to fix some of the short-term challenges. And probably if we can spruce up the capacity a little bit over the next few weeks, that would help. But I think it would be going to be a very challenging few weeks ahead of us.
Well, clearly we do. Dr. Malik, I wanted to bring this back to you. The flow, I had imagined that we would talk about the public health aspect of this, which we have. We would talk about the data, which I think we did. Then I thought we would talk about discourse, and then we would end with the strategy. But in fact, we've already had the strategy discussion. And so one of my sort of areas of really deep interest in terms of how big picture problems are going to get solved globally and locally is through really re-examining how the public discourse works. And that's why I think you represent a very unique kind of talent in our political spectrum, given your deep insights and knowledge, not just of health, but more broadly, the long elite strategy consulting career that you've had, and the various positions in government in which you've served. Dr. Malik, tell me if there's any hope at all of rescuing the public discourse from the extreme polarization that it suffers from, in order for us to be able to convince mid-tier leaders like DCs and ministers at the provincial level to senior level leaders like cabinet ministers, army generals, Supreme Court justices, and obviously prime ministers and chief ministers, given the incentives they have to go and follow the polls, to go in the polar opposite direction of what they think is their opponent. How will we extract better outcomes? How will we have a sophisticated, data-driven containment and suppression strategy that aligns with what you've articulated, what Dr. Khan has articulated, what Dr. Altaf has advocated, what Waqar is clearly endorsing and supporting, and what Naveed is also supporting? How do we get from where we are, where things are so difficult in terms of how we speak to each other at the national macro level, to convincing people right through the different tiers and across the system?
Muted me. Okay, so I'm unmuted. You know, there are a couple of things that I'd like to say before I get into your very specific question of discourse, and it will lead into that. So the first thing that I would like to say is, I mean, there was a data question that I raised, and I think Dr. Saiba said interesting things, and I don't disagree with it. It's very hard to know whether the presence of COVID-19 was a correlation or causal. How do you know? You don't. But then you come up with a global framework so that everyone responds and reports in the same way for the integrity of data, because we have data in the title of our today's conversation. So we all agreed that we are going to report in accordance with the WHO protocol. And we all said that we were going to test people dead on arrival all across the world. And most countries kind of complied with it. And we said, we'll report and we'll figure out oranges to oranges. We know what is working and what is not working. When you stop responding, when you basically say, well, let the rest of the world continue to report in a particular way, and even within the country, only one province report in accordance with KP, and that reports about 4 or 5% or 6% death rate, and the rest of the country just says we are not going to do it because we don't think it's causal, then it's very hard to make any policy. So purely from the policy and evidence perspective, if the evidence is not collected in a manner which has integrity, which has some level of uniformity, where you can do the comparisons and figure things out, then you're tough out of luck. Then it's my opinion against yours. And I think that is primarily what is happening. In terms of the effectiveness, even within our country, I mean, even with the way we report, our death rate per million people is twice as much as that of India. Indian death rate per million people right now is between 4.5 and 5, and ours is 9. The Bangladeshi is 5, we are about twice as much. The Malaysian is 4, we are more than twice as much. And the reason why I picked these countries is because you wanted to compare us with comparable countries where there were previously, and take Malaysia out, subcontinent, South Asia, poor countries with crowding problems, with similar cultural problems, and so on and so forth. So the question that you ask yourself is, what is the difference? Why is our death rate, even without conforming to the WHO, twice as much as India, Bangladesh, Malaysia, and 9 times that of Sri Lanka? 9 times that of Sri Lanka. So I think the primary thing is that we hung up on the word lockdown, and that's primarily because our leadership framed lockdown as a curfew. I mean, nowhere in the world, I mean, I use the word lockdown very loosely, and Naveed has very rightly used the word stringent confinement strategy, or whatever word you want to use, but I never said curfew, and no one has ever said curfew. We just are saying that even with the SOPs that we have no enforcement. You go out I mean, it's free for all kind of a world right now. You can do whatever the hell you want to feel like doing. And as a consequence of that, you have, the parliamentarians sick, you have the media people dying, the parliamentarians dying, you have the poorest of the poor people dying the most. And that's where we're at. And I see that as a very, very serious problem. Another question was raised about the death rate, the variation in death rate again across the world, and the examples were given that Spain has this, and Iran has this mortality rate, and France has a different mortality rate. Of course, mortality rate has a very high correlation with the kind of population structure that you have, and Pakistan has a very young population structure. About 85% of our population is under the age of 50. So the mortality rate in that group is going to be significantly lower. Whereas in countries which have 1 out of every 4 people is in elderly, the death rate is going to be significantly higher. It also depends upon comorbidities, upon hypertension, the prevalence of hypertension, diabetes, and other illnesses, particularly immune system diseases. So you put all of that together, and these numbers begin to make kind of sense. And that's why I was giving that example of, gravity doesn't care. Now, coming back to your question, the only way out, is evidence. There's no way we can have a political argument, my opinion versus your opinion. I mean, who can win the game of opinions? So it's I say, I feel, and I do. I mean, I can tell you what is happening in terms of anecdotes, and the plural of anecdotes is not data. So 2 of my brothers right now, within last week, are COVID-19 positive. No one has called us. I mean, you guys were very lucky that 19 agencies were calling you. Even my brother's wife was not called. Even the children were not called to ask, that are you guys, because about a month and a half ago, everyone was being tracked and traced. And now no one is being tracked and traced. I mean, I have about 12 family members who are COVID positive right now. We've not received one phone call. People living in that same household have not received any phone call. So if there is no tracing, if there's no tracking, if there's no testing, then what data are we talking about? How are we going to even build that evidence base based upon which we are going to then make policies? So the only way out to have a rational discourse or have the supremacy of rational discourse over political discourse is to do evidence-based policymaking. And at the heart of evidence is what you're calling data. We have to build this data. We are 4 months into the game, and what you were calling the Langdayal, that Langdayal is a very dear friend of ours, and we all kind of learn from him. But when the dust is settled, you would know that around March, April, I started to give these pieces across party lines and tell people that what kind of data is needed and how it needs to be collected and what should be the share of random sampling, what should be the share of testing and tracing and tracking, and how should we be treating the clinical symptoms, and how should we basically pull up the clinical symptoms and triangulate them with the testing that we are doing for symptomatic patients and titrate that against the random sampling and put all of these 3 pieces of data together to code yellow, red, and green kind of areas that can be opened, areas that can be shot, and areas that can have rather moderate kind of whatever word, I don't want to use the word lockdown because I don't ever mean it in
containment and suppression measures.
So what I'm trying to say is that we will have to all agree that in healthcare, the most important thing is evidence. And if you want to do evidence-based clinical decision-making for a patient or policy decision-making at a macro scale, you will have to build this evidence. And there is no point in using selectivity. We can agree on whether we are going to code it in this manner or that manner. But once we have agreed, or the world has agreed, that in this larger kind of framework, we are going to treat patients and code them death because of COVID or not death because of COVID in a uniform manner so that we can all look at the evidence and benefit from it, then there's no harm in subscribing to it. There's no harm in fudging data because we are cheating ourselves. At the end of the day, our policies would be suboptimal. So I personally feel that in order for us to rise, more we talk about evidence and less we talk about the federal government versus the provincial government, more we'd be able to move forward towards rational outcomes. I would say that right now the polarity in our political discourse is so sharp and it comes from the top. There's nothing you can do when it comes from the top. What can you do? I mean, if you want to talk about evidence, at the top you'll have to begin a conversation about evidence. But if at the top the conversation is going to be polarized and you're going to say that Sindh screwed up and Sindh is going to say the Fed screwed up, then it's going to be a very screwy conversation. And truthfully, in the absence of evidence, in the absence of data, in the absence of registries, in the absence of evidence, in the absence of culture, where you're making decisions based upon evidence and not ideologies, there's very little difference between ideology and ignorance. Both have an I in common, and evidence is an E. So let's move from I to E and use evidence to build our policy package and move forward in a rational manner towards optimal outcomes.
I think that
Musharraf, I have a question for you.
Please.
I have been wondering for many years now, whenever these things happen, and specifically now in relation to this epidemic that has been going on, and since this discussion is about discourse, my question is that what is the official process of discourse? Government is making, our representatives supposedly are making public policy. And why is that public policy not available for public review? I have not seen the parliamentary committee discuss the policy and the strategy that was made. I have not seen any public comments upon that strategy. I have not seen any comments that have been made by opposition parties. And there are people like us who are very much interested and who are capable of looking at I have somebody like me, and people who are my colleagues have almost 40 years experience of working in Pakistan at all levels, from the highest ministerial level to basically out in the trenches. So when we are talking about discourse, it's fine for us to sit and talk amongst each other, but the process of discourse by which public policy is discussed and made, where do we go to find that process?
I think that's a great question for us to wrap up on, Dr. Altaf. Before I do, I wanted to just thank each and every one of you. This has been such an enriching experience for me, and I'm grateful to you. Before I sort of close out and thank the audience, let me answer that question. I think that discourse, the way in which public discourse is constructed and generated, is changing dramatically and has changed in the last decade so dramatically that a lot of us that were manufactured in the 70s or 80s or 90s in terms of how we think about the world and how we think about how change happens and how we think about even data and evidence, a lot of those rules simply don't apply anymore, because oftentimes you will find social media influencers, or what many of us refer to as trolls, and that's not a degenerative term in any way, but people who are not experts, but who are loud and who are capable of garnering attention. Those voices are able to draw eyeballs and ears, whether it's on television or it's on social media. And just like all of us, I think our leaders, no matter what party they belong to, no matter what institution they belong to, they are also human. So I think discourse is very different today than it was over the last many decades. And this effort, what we're doing right now in collaboration with our friends from Corporate Pakistan Group, and with the generosity of the five of you and all of the fantastic folks that have been tuned in throughout this conversation, what we're trying to do is maybe balance things out a little bit, so that for all the screaming and the hair pulling and the name calling and the polarization and the toxicity, there is a space in which we can engage with each other in a way that helps us forge some common ideas despite our differences personally and politically. And I know that there are differences in this group of six, or rather five fantastic experts, both personally and politically. So that's maybe a little bit of a cop-out answer. I think it merits maybe a whole new roundtable to talk about how communication strategies are formed in government and what we can do to help make them better. But for this evening, given that we've exceeded our time, I want to, once again, I want to thank you, Dr. Samuel Toth. Thank you, Naveed Qazi. Thank you, Waqar ul Islam Saab. Thank you, Dr. Mishal Khan. And thank you, Senator Dr. Musaddiq Malik. All five of you really added tremendous value. I hope our audience felt the same way. Thank you also for the questions and the running commentary, which I was checking regularly. We had a fantastic debate on YouTube as well, and the speakers may like to go and visit the site and see how enlightened our audience was as well. Thanks once again, and we'll catch you on the flip side, inshallah. Khuda Hafiz. On